Good morning and afternoon, everyone. Welcome to today's webinar, and thank you for joining us. My name is Dr. Leah Wiggum, and I'm the director of the UT Health Center for Community Health Impact and an associate professor of health promotion and behavioral sciences at UT Health School of Public Health, El Paso campus. Today's webinar is hosted by the Michael and Susan Dell Center for Healthy Living at the UT Health School of Public Health Austin campus. The center's vision is healthy children in a healthy world. And the Michael and Susan Dell Center is co-hosting this with our Center for Community Health Impact located in El Paso, Texas. Before we get started today, I just want to make some housekeeping announcements. This webinar is being recorded and will be archived along with the presentation slides on our website at msdcenter.org. If you have any questions during the presentation, please enter them into your questions chat box. We will have time for Q&A at the end of the presentation. If you're watching this webinar from El Paso, you can also join us in person at our campus following the webinar for a live Q&A with Dr. Dhurandhar. I'd like to thank Olivia George from the Michael and Susan Dell Center for Healthy Living for providing technical support for the webinar today. I'm excited to introduce our speaker today, Dr. Nikhil Dhurandhar. Dr. Dhurandhar is a professor, Helen Devitt Jones Endowed Chair, and Chair of the Department of Nutritional Sciences at Texas Tech University in Lubbock, Texas. He is a past president of the Obesity Society and editor-in-chief of the International Journal of Obesity. As a physician and a nutritional biochemist, he has been involved with obesity treatment and research for over 4 decades and has treated over 15,000 patients for obesity using lifestyle therapy as well as medication. His research focuses on molecular, biological aspects of obesity and diabetes in particular, obesity due to microbes, and clinical treatment of obesity. I will now hand it over to Dr. Dhurandhar to start his presentation on addressing obesity at a population level, integrating solutions for causes and contributors.
Thank you, Dr. Wiggum. Good morning. I would like to start by thanking Dr. Deanna Helsher and the Michaels and Susan Dell Foundation for Healthy Living, Dr. Leah Wiggum and the Center for Community Health Impact for this opportunity to be here, for the invitation. I really appreciate that. I would also like to acknowledge and thank College of Human Sciences at Texas Tech University in Lubbock, Texas, where I am from, for supporting this event and making this happen. And of course, thank you all for taking the time to log in today. So let's get started. The title is Addressing Obesity at a Population Level, Integrating Solutions for Causes and Contributors. I would like to start by first making a first key point is by defining obesities. Note the plural instead of obesity. I would like to say it's obesities only to make a point that it is a collection of diseases with multiple causes, contributors, and clinical expression, much like the word cancer. That cancer is not one disease, but it is a group of diseases with different causes, different treatments, different expressions, and so on. Common view of obesity is that obesity is caused generally by eating too much and moving too little, or it results from a poor diet and lifestyle choices. And this particular one is on the website of National Health Services of United Kingdoms. I respectfully disagree and would like to mention that this view needs updating. Because, for example, swelling or edema, water retention in body, is not caused by drinking excessive water, but it is due to impairment in water balance regulation. As you can imagine, usually water in and water out are equal, but when something goes wrong in that balance, something wrong with the heart, something wrong with kidneys, that's when we start retaining water and causes edema. Similarly, obesity is due to impairment in energy balance regulation. In a healthy state, body fat is maintained within a range. If we start gaining too much fat, or if you start losing too much fat, body, so to say, jumps into action, has many tools at its disposal, such as modulating metabolic rate or hunger or fullness, so as to keep that fat accumulation within a range. That's what normally needs to happen. But when this homeostatic system is impaired or overwhelmed, that is when you will start experiencing excess fat accumulation, and that would be considered expression of obesity. So alternate view of obesity I would like to present is that obesity is caused by an inability of the body to maintain fat within a healthy range. That defect is what I would call obesity. And of course, there are causes of obesity and contributors of obesity. On your left side, you're seeing causes of obesity are what I consider them as intrinsic within a person, or they are acting in a person, that it can induce obesity without the help of contributors. As of today, these causes are non-preventable, but thankfully they are treatable. Contributors, on the other hand, are extrinsic. They are in the environment. They can lead to obesity in presence of causes. They are preventable, modifiable, treatable. And if you want, if you're interested in more information about more details about this, we published a manuscript recently, and this reference is down there. It is in Nursing Clinics of North America, if you needed more details and more explanation about it. So here are some examples. This is non-comprehensive list of causes of obesity. It's just few examples would be gene defects such as deficiency of leptin gene or melanocortin 4 receptor, or lower levels of thyroid, hypothyroidism, or certain infections. These can all cause obesity. Contributors may look something like this. Energy dense food, because remember these are outside in the environment. Energy dense food, large portion size, or ultra processed food, or food insecurity, all these contributors can act through those causes to result in obesity. This is a little bit more explanation of this relationship of contributors and causes. If you look at contributors, they're blue colored, something like structural racism or low socioeconomic status or food insecurity. All these independently or together may act, these are all contributors, they may act on a person, in a person, and increase the stress levels. That could lead to hormonal disruption, maybe increase cortisol secretion, which may lead to expression of obesity. So this is how contributor and causes relationship could be viewed. And that obesity, again, in turn, could increase stress within a person, that will perpetuate this cycle, or increase obesity, may also lead to obesity in future generations. And this is just one small example of a one loop, or there can be layers upon layers of these relationships of contributors and causes leading up to obesity. This also helps us in addressing obesity effectively. If I were allowed to make only one point today in today's presentation, so here is what I would like to say. Let's imagine that although it is very hard to completely get rid of racism or change lower socioeconomic status of individuals, or completely get rid of food insecurity, let's just imagine that today, by some magic, we have none of this existing. We took care of it. What would that mean? So those contributors, let's just imagine, have gone away. That would mean that we may be able to reduce or eliminate future obesity, their contribution to future obesity. But what about the obesity that exists today? There are people who have obesity today, and there are 185 million adults with overweight or obesity in the United States. Obesity in an individual is not spontaneously reversible without substantial and sustained negative energy balance. Let's just think of an example, an individual, let's say a woman who is 400 pounds, has diabetes, high blood pressure, and other conditions that come with obesity. And if we removed stress or racism or food insecurity from this person's life, that person is not automatically going to start losing weight from 400 to 300 to 150. Her diabetes and other conditions will need to be addressed, so as the obesity will need to be addressed. Another example would be excessive exposure to UV light can contribute to, say, skin cancer. But once you get skin cancer, removing that person from exposure to sunlight or putting that person in shade is not the answer. It's not the treatment. Once that person gets skin cancer, that skin cancer will have its own treatment. Similarly, treatment of individuals affected of obesity is imperative. That brings me to the second key point, and that is obesity treatment requires substantial chronic negative energy balance. So if your requirement of calories for the day is 2,500, let's just assume, and if your intake is around that 2,500, you may maintain your weight just in about that ballpark. But if you do want to lose weight, you have to take fewer calories than your requirement, maybe 500 calories less, maybe 1,000 calories less, but not one day. That has to be done day after day, week after week, month after month. And that's what that substantial and chronic negative energy balance means. So why is this important? Because general weight loss suggestions do not produce meaningful weight loss. And if you want some example, think of placebo groups of a weight loss drug trial or any other trial where there is a control group and there is an intervention group. And the control group typically ends up getting counseling for diet and physical activity. Maybe they are asked to eat less, move more, eat smaller portions, eat less fat, and so on. And what happens as a result? This control group that got general suggestions, not very specific, not individualized, if any, they will end up losing 1 or 2% of body weight in a year. And mind you, this is in a very highly motivated group of individuals. They are participants in a study, not just free living population. Also, they are in the best of hands, best of researchers in the world, and yet it doesn't show much effect. So here's another example. I put in some weight in this My Plate plan, which is a USDA plan, and it gave me, if I have to lose weight, I need 2,200 calorie diet, and it gave me different food components, how much maybe I should be eating, maybe 2 cups of fruits and 3 cups of veggies and so on. Let's just focus on one of these components, that is protein. Okay, so here it shows that 6-ounce equivalent of protein I should be taking for a 2,200 calorie diet for weight loss. And the website shows all these foods that one could eat through which one could get 6 ounces of equivalent of protein. and that's fish, chicken, meat, eggs, beans, or nuts. All those could provide proteins, the required amount of protein. But if you look at the calories, if you get your protein quota through fish, you're going to get 200 calories. If you're going to get that protein quota through your nuts, you're going to get 700 calories. You may get same amount of protein, but 700 calories. That is a 500 calorie difference across equivalents. So it would be so variable from day to day just with protein. So unless it is, the point I'm making is these are general instructions, and of course it is very hard to be more specific in general guidelines, clearly, but that will introduce so much difficulty in weight loss for an individual. Therefore, unstructured weight loss instructions are less likely to succeed. On top of it, people are not always familiar with their own calorie requirement. How many of us can raise hand and confidently say, my today's requirement was 2,450 calories, and tomorrow's is going to be 2,600 because I'm going to work out more or what have you. We are not that familiar as a group of individuals. We are not familiar with calorie value of foods. Not all foods come in packages with calorie stamp on it, right? Nor do we may not be able to accurately assess our physical activity calories in terms of physical activity. To make matters worse, body kind of resists weight loss. It doesn't seem to like weight loss, and it resists that by decreasing metabolic rate, decreasing satiety, and increasing hunger. So with all this, negative energy balance is difficult to achieve and sustain, especially if there are just generic guidelines and instructions, and therefore we need individualized and structured treatment for people with obesity. Now, what is the role of public health efforts in addressing obesity? And I'm not going to be comprehensive in covering that, but some aspects I would like to share with this. These are some of the efforts. Again, this is a huge area, and there are lots of other efforts going on in this area, but I just want to use a few examples here. So efforts are underway to improve population health, clearly by increasing fruit and vegetable consumption, increasing physical activity, reducing added sugar or sugar-sweetened beverage consumption. Here is an example of what some data and trends in the United States across some years. And you can see that about 34 to 32% of the individuals reported that they eat fruits 2 or more times per day. And that has been the trend in those years from 2008 to 2000 over time. Same way, about 26% of people reported that they were eating vegetables 3 or more times per day. So that seems to be more or less steady prevalence or report. Here is something that is actually exciting: trends in meeting the physical activity guidelines in adults. And those people who had no physical activity, that's what they reported. There were 36% of the people in 2008. And that number decreased to 25% in 2018, which is a good thing, that there are fewer people who are reporting no physical activity. And if you look at people who are reporting moderate intensity, that is 150 minutes or more per week, there used to be 43% people reporting that in 2008, and now it's 54% in 2018 reporting that activity. Same with 28% to 37% for individuals reporting activity more than 300 minutes. So there seems to be a trend of increasing physical activity. Here is another heartening trend: added sugar out of calories consumed seems to be coming down over time. Sugar sweetened beverage calories in total calories seem to be coming down over time. So these seem to be encouraging trends. But at the same time, look at what's happening for obesity prevalence. Obesity prevalence seems to be increasing over all this period. So the point I want to make is that we seem to be going in the right direction in terms of increasing physical activity or reducing sugar intake or sugar sweetened beverage intake, and that may certainly improve individuals' health. But a key question to ask is whether that is translating to addressing obesity. Improving health is excellent, but that doesn't necessarily mean that we are able to address obesity effectively. So that brings us to a point that we need to be candidly introspective about what works, what does not work, or what we don't know about, or why. Here is one example that comes to my mind. Much has been thought and written about the built environment and obesity connection. That means it's about against urban sprawl and not having enough space for recreational space, not enough parks, not enough place to walk or sidewalks or what have you. And that has been linked intuitively with obesity. And efforts have been made to change that so that obesity can be addressed. And here is a paper that is a systematic review of 36 systematic reviews. And one of their conclusions was that most studies have not been able to confirm the assumed influence of built environment on weight. So please understand that this is not against having parks and recreational spaces. They are important in our life and they're good to have, but is that changing, addressing, influencing obesity is a hard question to ask. Another such example is emphasis on a single food item, such as an example would be sugar sweetened beverages, that one should be reducing sugar sweetened beverage consumption. And I agree, I support it wholeheartedly. I agree those are empty calories. I don't like it myself. I would not recommend that somebody should go ahead and take more sugar sweetened beverages. But the question is, removing those from your life, does that address obesity? And here is one example to give there. If you look at this buffet, and there are so many dishes here, and if you think that people are going to get too many calories eating this at this buffet, so I'm going to remove 2 of these dishes from the spread so that they will eat fewer calories. Is that going to happen? Well, it's not going to happen because people are not going to miss those 2 dishes that you removed, and they are going to, other sources of food are going to fill that gap of calories, which I call digging a hole in water. So my third key point would be addressing obesity meaningfully would require treating existing obesity, treating obesity of today, and preventing obesity of tomorrow. Treating obesity of today would require individualized, effective, and wide-scale treatment of individuals. Preventing obesity of tomorrow would require minimizing additional expression of obesity. So when integrating solutions for causes and contributors, a strategic plan partnership for addressing obesity at individual and community level may be needed using complementary approaches. It's not one or the other. Both approaches are needed. And while there are many scenarios possible, I'm just going to select just a few to share my thoughts on this topic. of course, there can be situations that can be outside of the examples I'm giving here. So next few slides, you're going to see this division. The one on your left side would be how one could approach in an individual when you're addressing obesity. On the right side is how a system-wide change and environmental change can be used that facilitates and that is sort of complementary to in action. So here's this one example is about role of sleep. So we know that poor quality or quantity of sleep can contribute to weight gain. In an individual, this could be a factor such as sleep apnea. If somebody has sleep apnea and if you don't address that, that person will continue to have poor sleep and that may contribute to weight gain. So in an individual, one has to consider physiology, what could be contributing to that weight gain. So on the other hand, system-wide, one could address the same thing, poor sleep, but through addressing conditions that lead to disturbed sleep in a neighborhood, in a community. For addressing obesity, of course, one has to support reducing energy intake. And for an individual on your left side, it could be through personalized diet for creating that negative energy balance. It could be also development of effective tools and strategies, diets, drugs, surgery, devices, what have you. On the system side, if one can have conducive environment that will promote that negative energy balance, and that could be done by creating awareness about obesity or screening of individuals, access to care, and availability and access to lower energy density food options, so that people who are quote unquote dieting are those who are trying to have negative energy balance. It becomes easier for them, and with considerations for taste and cost, of course. Third example would be promoting energy expenditure, and that would require increased physical activity. And this physical activity could be personalized physical activity prescription, because not every individual can do all sorts of physical activity, nor it may be suitable for them. So it may be individualized physical activity prescription, or if and when drugs or devices become available for the same. A corresponding system-wide change could be resources to encourage physical activity. That could include policies, resources, creating awareness, or easy access to facilities where people can increase physical activity. So this is how these two could go hand in hand. Another one is facilitating widespread treatment of obesity. As I was mentioning, we have millions of people in this country who need obesity management. Just a few people getting treated for obesity here and there is not going to cut it. And we have too few obesity specialists in the country that we cannot just depend on only their help. We have to recruit a broader effort on part of primary care providers such as physicians, nurse practitioners, physician assistants, registered dietitians. All of them will be able to offer wider spread treatment of obesity. Now, on the system side, how this can be done? By increasing obesity management training in medical schools, which is inadequate today, or by having greater and better tools to manage obesity, or insurance coverage or access to care. Insurance coverage is not an issue only of insurance companies or your employers or individuals. It is a matter of generating awareness about obesity being a disease and obesity, reducing obesity stigma so that obesity is seen as a real disease that requires real treatment, just like cancer, just like diabetes. So those are the opinion generation that can lead to policies that can eventually lead to insurance coverage and access to care, as an example. And finally, minimizing obesity expression. So we're talking about expression of future expression of obesity here. And in an individual, that can be done at two levels. One is by identifying individuals and preventing weight gain in the first place, or those who have lost weight, preventing weight regain in those cases. So identifying additional risk factors for obesity development, as research would tell us about it. We don't know what we don't know. So we don't know how many risk factors are out there and we don't know about them. So identifying those, identifying at-risk individuals, screening individuals for various gene defects that we can do something about, or diseases, conditions like hypothyroidism so that they can be effectively treated. That can go on in an individual. System-wide, it could be resources to minimize risk factors for obesity expression. Just the example we took some time back, we would make efforts to reduce structural racism or food insecurity or provide economic stability. Those would be some examples of minimizing obesity expression in the future. So in summary, obesities have causes and contributors. That's one. Second, effective obesity treatment of an individual requires a structured and personalized treatment approach. On the other hand, effectively addressing obesity on a national level will need integration of two things. One is treatment of those who are already affected, effective and wide-scale treatment of individuals, and supporting system-wide changes. And second is prevention. That will be through minimizing excess weight gain or regain in at-risk individuals, and by minimizing system-wide risk factors for obesity expressions. So those were my thoughts. Thank you very much for listening, and I'll be happy to discuss any of these topic issues with you. Thank you.
Wonderful. Thank you so much, Dr. Dhurandhar. I'd like to go ahead and remind everybody to put your questions into the question in the question field in the chat box. And Olivia is going to help facilitate our Q&A. She's going to send me your questions so that we can discuss them with Dr. Dhurandhar. While we're waiting for those questions to come in, I'm going to start off with a few observations and questions of my own. So it seems to me, Dr. Dhurandhar, that building upon this framework of causes and contributors, one reason we may not be seeing an impact on weight specifically from these environmental focused intervention efforts, when we see studies that target sidewalks or parks or grocery stores in community settings, and then look to see if there's a change in weight, we often don't see an impact on weight or obesity levels or prevalence in those communities. It seems to me that that could be because there is not a parallel effort to ensure that the individuals living in those same communities have access to evidence-based treatment from healthcare professionals who have the knowledge and skills to work with patients to address the causes of the obesity. So those environmentally focused strategies are only focused on the contributors, and if there's not a parallel effort in the same population, in the same window of time to address the causes, what you're saying is we're not likely to shift obesity at a population or community level. Is that correct?
This is exactly the point I would have loved to make. That's exactly what I think. And that's the example I was giving, that these two things need to go hand in hand, treating individual as well as addressing the environment. We can't afford to do just one of the two and leave other for it to happen magically. So the point you made about having parks or recreational areas, that will provide that opportunity for increasing physical activity. But then there has to be a parallel effort where people are trying to eat less and move more, and then this environment will be facilitating that to happen. The other example was people, we are expecting individual treatments for them to eat less. And if we expect people to eat less that is not tasty, that effort doesn't go very far, right? People will not be able to comply with eating cardboard for a long time. So if, on the other hand, if we have efforts where we have food that is tasty, reasonably priced, that is available, now we have a combination of this effort in individuals and there's a supporting environment for that, then we may be able to see better results. That's exactly how I see it.
Okay. Can you elaborate a little bit on that first example? Why shouldn't we expect that if we have more opportunities for physical activity in the community, why isn't that enough for people to then just, everybody knows they need to exercise to be healthy and that exercise is part of managing your weight. So why isn't it enough? Why is treatment in parallel to having those opportunities for physical activity necessary? Why isn't it enough to just tell people, go out and exercise?
Excellent question. So let's just say that we need to reduce maybe 500 calories from our requirement. Say we need 2,500 calories a day, and we need to end up with something like 2,000 calories in a day. So we have a deficit of 500 calories, okay? And that's how we may lose maybe a pound a week or something. Now, two things can happen. One is exercise is, see, the word exercise or physical activity has so many different reasons why one should have physical activity, why one should exercise. There can be aerobic fitness, there can be muscle fitness, that you want to improve your muscle, you want to improve your stamina. Calories is one of those benefits of physical activity. However, the number of calories that are used in a regular physical activity session is not too many. One example would be 1 mile of walk, whether you walk or run. 1 mile is about, depending on your weight, but it's about 100 calories. 1 bagel can be 300 calories by itself. So if you eat a bagel, you have washed away your efforts of walking 3 miles. So it's not that you should not be walking. It's not that you should not be having physical activity. As I said, physical activity has many reasons why one should do physical activity. It also preserves muscle mass when you're losing weight. So there are many benefits of physical activity. But if you think that I'm going to do physical activity and then I don't need to follow that diet and I'm going to lose weight, that doesn't seem to happen. So that equation of energy balance, physical activity is only one small part. There is food intake that has to be monitored at the same time. When the two things combine, that is when you are more likely to have that energy deficit and lose weight.
And then as a physician, Dr. Dhurandhar, I know from working with you in clinical contexts, I imagine you've got many patients who it may not be medically advised to start with the physical activity until they've received treatment in such a way that leads to weight loss, which then makes the physical activity feasible. Can you elaborate on that?
Yes. Yes, that's another excellent point. And that is one of, briefly, I mentioned that not all physical activity is suited for all individuals. Sometimes I feel that, see, when somebody has obesity, in in addition to everything else, metabolic load, that weight is putting mechanical pressure on this person's body, in joints, in weight-bearing joints, back on the vertebral column, hip joints, knee joints, ankle joints. They are all under pressure because of excess body weight to start with. Sometimes people have such excess body weight, and I see very bad sometimes when I see kids, especially, who have obesity, and maybe their parents or maybe their coaches are making them run because they're well-intentioned, but their impression is that if you have somebody who has obesity and you make that person run, that is going to help their obesity. It may not. It may damage their knee joints. It may damage their hip joint. It may have some effect or impact on their heart. So one, a safe weight, so to say, is to have physical activity that uses up some calories and gets some benefits, yet without the damage. And I generally like to say slow and level walking, not climbing up, not climbing stairs. Slow and level walking, not running too much, would be a good way to start. And in some cases, it's also possible that I remember a recent example of a patient who could not get out of her bed, and she could not stand up. So to make this person, tell this person that you need to walk is not going to be useful. In this case, she starts losing weight. As she started losing weight, one of the things we mentioned to her was to use her arms and exercise her arms instead of legs because she could not stand up. And as she lost weight, she got more confident. She started standing up. And then the next step would be for her to walk a few steps every day and increase that activity slowly. So that's just an example of how one could add physical activity and not go crazy, so to say, right from the beginning.
Okay. We do have some questions coming in from our viewers. So I'm going to ask the first question from the audience. Can you speak to how corporations or large companies influence obesity? For example, how millions of dollars are put towards creating food products that are highly palatable and how that influences individual choice. Are there systems level solutions to this?
So this will require perhaps an hour of discussion, but let me just make it concise. I look at this issue slightly differently. When it comes to weight loss and creating negative energy balance, I feel that there are very few foods that I would consider absolute taboo. It is the amount that you eat is very important. I think my pragmatic view about making somebody let go of all the tasty food or good food or something in their life that they look forward to, and making somebody eat only things that are plain and may not be as tasty, the person may not be able to stick to that diet for a long time. So be it tasty food, be it fast food, be it food, ice cream or what have you, these are some foods that people can enjoy because you want to keep their quality of their life. You want to preserve that quality of life. So instead of seeing corporations or instead of seeing that these foods that exist today in our environment as enemies, I would rather work with those foods around us because that's reality, and determine in how we can enjoy that in moderation and yet lose weight. So that would be my approach instead of making a list of things that one shouldn't totally be eating.
And if we kind of shift this from the individual level to the system level, I was just working on a communication about this very topic yesterday, in fact. Oftentimes, as a nutrition professional, I get the message from colleagues that they see the food industry as kind of this monochromatic evil industry, trying to drive profits through making tasty foods. But as you and I both know, because we have colleagues who are in the food industry as well, there are many well-intentioned food industry professionals who genuinely want to positively impact human health. And by partnering with food industry, rather than creating sort of this antagonistic tone with industry, there can be great potential and a lot of power. I mean, this question mentions the millions of dollars spent by food companies. Why not harness that power to develop marketing campaigns, to develop products that can help people with weight loss, that can help people achieve their goals? And so I think from a system level, it's important to keep in mind that cooperation rather than kind of a battle mentality can be really powerful. And I'm wondering if you can comment just briefly, bringing it back to the individual, how important some of these food products that industry does develop can be when you're working with an individual to treat their individual cases of obesity.
Yes, what you said is, I agree with you very much. I like to see all those who want to be a solution to our obesity issue. I would rather see them at a table. That those who want to help, those who want to be a solution, I would like to work with any or all of them, and not say that because you belong to a particular industry or particular background, you are not welcome. If you want to offer a solution, I would like to work. And as you rightly mentioned, there are so many food products that are available that are, I use them on a daily basis when creating a diet plan for someone that are lower calorie food, higher protein, or low energy density. So there are multiple options available that taste very similar, yet provide fewer calories or provide greater nutrients, and they have all resulted from food industry development and food science development. So those are the bright side result of collaboration.
Okay, so we do have several other questions here. I'm going to try and push through them in the next 5 to 10 minutes. Another comment and question from the audience. I'm glad to hear you include the PCP. Presumably they mean the primary care provider. Reliable sources of health and weight loss info is missing for most people. Primary care doctors can be that person when they have specific training, as can registered dietitians. What are the steps forward for increasing physician knowledge, or I'll substitute that with primary care provider knowledge of obesity treatment, and more availability for dietitian paid consultations?
One of the ways that one can increase knowledge, awareness, training, skills of all primary care providers, be it physicians, nurse practitioners, physician assistant, dietitian, is training for obesity management. Now think of as one example, think of medical school. I went through medical school without ever hearing any word about nutrition. Forget about obesity. Obesity is a small part of the big field called nutrition. And yet I didn't hear anything about nutrition in the first place. Many of our medical schools, we have doctors graduating from medical school without having treated a single patient for obesity management. They do treat people who have obesity, but not for obesity. And then naturally, they tend to focus when they are busy in practice and when there are so many things to attend to, they tend to focus on treating diabetes, treating cholesterol levels or high blood pressure, but not the cause of obesity, because they may not have received adequate training. There are many ways to approach that. There are certifications called American Board of Obesity Medicine, or ABOM certification, that individuals, doctors, physicians can get. There are courses and training courses by very reputable universities that are offered for obesity management. So these are all efforts underway. And I think, let me just very briefly add something, a different perspective here. One of the things that will really help this effort of primary care providers treating or taking on obesity, treating obesity, in addition to training, is reimbursement for their effort. And currently, it's a cycle that if individuals cannot accommodate a person for which they are not getting reimbursed, so they have to focus on the contributors, the diseases that are right in front of them. It is very hard for somebody to take off time from their practice and treat something that is not reimbursable. If it becomes reimbursable, and in some cases it is, it depends on individual providers and insurance companies, but if it becomes widely reimbursable, there is going to be more sustained interest in treatment of obesity.
Okay. All right, we have about 4 more questions at least that we want to get through here, so let me get right to those. Some people with obesity don't want to be considered diseased or ill. How do you deal with this situation?
I think it is it's a way that it may be a result of what they have bias they have experienced in the first place. So, and what is the alternative? What is the alternative to be considered if it is not a disease? What is it? Is it a behavioral issue? Is it your lack of willpower? Is it because you want that obesity upon you? So these are all stigma generating opinions that people have had over time. I think it is very important to explain to people when we say that it is a disease, what does it mean? It's not like that it's a disease that you're a bad person. It is a disease just like diabetes is. Somebody has diabetes, then they get treatment from their healthcare provider. Same way somebody has obesity, they get their treatment from their healthcare provider. In that sense, this should be considered a disease.
Okay. How does the treatment for obesity differ for children? Is there a strategy you can recommend to encourage students to eat healthy and exercise that will motivate them to minimize obesity?
Okay, a number of responses, but let me start with the last one. Eating healthy and exercising does not take care of obesity. It has something more required. Eat healthy and exercise is excellent, and one should do it. But just because you ate healthy and you exercise, you may not lose weight. So that's the whole point I was making, that one needs a very structured, intentional, purposeful approach to lose weight. Second, obesity in children is a very special case, which is very different than obesity in adults. And we have limited number of drugs or approaches compared to what one can use in adults. Third consideration, in children, it depends on the age. If you're talking about somewhere around 5 to 10 years old, or we're talking about teenagers, there are 2 considerations. In both cases, reducing diet, giving fewer nutrients, has to be done very carefully, because that can impact growth of a child. So you don't want to compromise. You don't want to give less nutrients, less calories, so that it will impair that growth. So one has to be very careful and strike that balance in children. So if one has the luxury to do that, one can do it in such a way that you hold weight of a child in a way that when the child is growing in height, that eventually that excess weight will become more like more usual weight, in the sense, instead of actually actively reducing their weight, prevent weight gain so that they will increase their height, they will increase their age, and eventually that weight will become okay. In teenagers, there is another complication because they are not as much inside the house and as much under the guidance of parents or parental care, and they are more freedom and more avenues to lead their life. It becomes even more complicated, and it's a complex situation where one has to carefully address the desire for freedom of an individual feels, the peer pressure that an individual feels, and accompanied by requirement to manage their weight as well. So it's a very complex issue, and it should be done by somebody who knows well how to deal with this.
Okay. One more question we have here, and I'm going to take the liberty of starting the answer for you and then asking if you want to contribute to it, which is, sorry, I lost track of the question. Can you give some examples of effective community-wide interventions to improve nutrition? And I was just in a conversation last week about a great example of this, so I'll start it off, and then if you want to add to that, you can. I'm also going to take the liberty of changing the question to say community-wide interventions to improve obesity, keeping in mind that if we're talking about improving nutrition, we have to ask how are we measuring improvement in nutrition. And I'm not aware of community-based, community-wide interventions that have had a marker of nutrition. Nutrition is a complex set of identifiable characteristics. There's not one thing that you can measure to say we've improved nutrition. You can measure BMI as an indicator of obesity, and so I'm going to answer this question in that context. So many years ago, there was a progression of activities where much of this work kind of coordinated and collectively drove some change right here in the Paso del Norte region in El Paso. And it was a combination of work that was led by UT Health Science Center School of Public Health. Researchers from UT Health had developed a coordinated school health program called CATCH, which many of you have probably heard about. Through their work to get evidence-based program established, measured through federal grants, and then to get that moved to a foundation. They started a foundation that could then disseminate that program, the Catch Global Foundation, which is an important component. Universities don't typically run these kinds of programs at a large scale. So their vision to transition the program that they developed through research into a foundation that could then take over the dissemination was key factor. In addition to that, they worked closely with Texas state legislators to put legislation in place that requires schools to have a coordinated school health program. Because oftentimes educators have so much on their plate that just knowing that a program is out there, it's battling with so many other priorities. This is one example where policy can come in and drive decision-making or drive priorities at the level of, for example, schools. So legislation was put in place that requires coordinated school health programs. At the same time, another key component was happening here in El Paso, which was thanks to a foundation called the Paso del Norte Health Foundation. And they were funding some coordinated efforts across the community. One was called Move El Paso. One was called Que Sabrosa Vida, which was a culinary cooking nutrition program. Move El Paso was a community-based physical activity program. And so there is evidence to show that during that window of time where there were these coordinated efforts within the community funded by the Paso del Norte Health Foundation and this statewide effort that required schools to provide coordinated school health evidence-based programs. And in the case of El Paso, those districts were using CATCH. We actually saw measured rates of childhood obesity decrease through the SPAN project that's run out of the Michael and Susan Dell Center. and through BRFIS data, national CDC data, decreases in adult obesity rates. So it is possible, but it takes, that's a lot of coordinated moving parts, a lot of smart people working together simultaneously in the same population in the same window of time, and it takes funding. And those funding opportunities are not always sustainable. What drives funding decisions can shift and move over time. So we are at the end of our time. I'm sorry that we didn't get to one or two of the remaining questions, but please feel free to follow up with the webinar recording that'll be available at the website. And thank you all for joining today. And thank you, Dr. Dhurandhar, for sharing your thoughts with us today.